approximately prior to trauma, history she gave you, where she fell on the floor of the grocery store on August the 16th, 2009.
Yes. Yes, and I felt because so no pain before the injury.
No other history of another traumatic event.
That's my there was none. There were no other injuries. There was the injury in August. She saw attention first by Dr. Tremaine. Apparently her primary care, Dr. Davidson, had ordered an MRI right away, which revealed the issues with the fat pad and the tendon and the bursa, and then with different therapies and other modalities, the pain persisted, so we proceeded directly to a diagnostic arthroscopy and found that there was a meniscus tear.
Now, you came in before your first meeting with having had an MRI on or about September the 3rd of 2009, did she not?
Yes, sir.
And did you have an opportunity to look at that?
Right now,
result?
We did, yes.
And I think we covered part of it, but I want to go back to that. That was inconclusive insofar as what you ultimately found to be a torn meniscus.
Correct.
That didn't surprise you?
Not a bit. No, it's not uncommon. Well, it's not uncommon. The meniscus already, as we said, the MRI is 85% sensitive and specific. So that's good. That's a threshold that we can work with.
It's not 100%.
It's not 100%. 15% of the time it says something is there that's not, or something is not there that is there.
And in this case, you verified that there was something there that the MRI on September 3rd, 2009 didn't show.
Correct.
After your surgery, what course of treatment did you suggest and prescribe for Klein?
So I was with people the next day after surgery to go over the pictures, answer any questions, make sure the pain controls managed, all of that stuff. So when we did that, I was placed people that have meniscus repairs and knee mobilizing for 2 weeks' time, weight bearing is tolerated, and then ice and pain medicine.
Probably disabled at that time?
Well, on crutches.
I'm in mobility,
Yeah, well, it relates to knee immobilizer and crutches, yeah.
All right. And what else did you suggest or prescribe?
Well, we do that for 2 weeks' time, and then after 2 weeks, we see people again. We look at their wounds, make sure the wounds are healed, there's no other issues, and then we proceed with physical therapy. First, centers we want range of motion. That's important to attain first. We get motion and then strength. Once the motion is obtained, then we proceed with strengthening. The next visit, we saw Miss Klein, we had we was leaning off the immobilizer and the crutches, and we proceeded with therapy.
Let me interrupt you for a minute. Remember what you brought up because I want to go back. A little perhaps forgetful, or what occurred to me, that when you were doing the arthroscopic surgery, what did you do to repair the tear?
So we have a technique that we use that's called an all-inside technique. The first thing you do is you take a small, once you identify the tear with the probe, the wire probe, you that area, you take a small, it's called a rasp. It's about the size of a bead, but it's steel and it's got little serrations on it. And you just kind of wave it, rub it over the tissue, the capsule and the meniscus on both sides to try to enhance the inflammatory response. We're basically making it inflamed.
You're agitating the surface.
Correct.
When it's inflamed, it grows back together better?
Yes, sir. It increases the blood flow, which is going to generate the cells of healing to come to the area. Then we take a needle and we pierce the meniscus in the area of the tear to cause bleeding. What you're trying to do is generate channels that draw blood vessels from the vascular lining into the meniscus. It's kind of like, I look at it like spot welding. Exactly. And then to stabilize that meniscus, after we irritated the capsule with the brass and toughened the meniscus with the needle, then we take these little dissolvable tabs that are pushed through a small cannula to secure the meniscus, to make it stable, so that all of this new environment that we've created in this little microenvironment in that meniscus has the best chance of healing that meniscus.
So you came out and closed. You then retracted with physical therapy, and how long did that take?
Well, the therapy usually we go after we wait 2 weeks, let things the healing process begin. It's a gentle range of motion, and then after the motion is attained, then strengthening. That process usually takes in the face of a meniscus repair, because things go a little more slowly because there's more inflammation and that we create to help hedge our bets, as it were, to get the meniscus to heal. And so then we proceed with range of motion strengthening, and that takes about 12 to 16 weeks.
All right. Did you do that in the hospital, at home, at a physical therapy department? So, do you know?
Physical therapy is at home.
All right. At some point in time, you suggested, let me get ahead of myself. At some point in time, she came back to you, did she complain that healing process had not completely released her?
Yes.
And when about was that? Did the record show?
Yes. The next visit was 2nd of April. Recheck evaluation. Still using brace and crutch. The wounds at that point was 2 weeks out from the surgery. The wounds were well healed. We started therapy, weaning off the crutches and immobilizing. Started that again at the end of the month, the 30th of April. Things had improved to some degree. Range had improved, strength had improved. There was still some discomfort that persisted. With the continued discomfort, though, at that point we ordered a second MRI because there was still so much, there was still pain. I don't know if I had MRI. Maybe I do.
When was that taken?
I have an MRI from the 27th of August.
Now, this was approximately a little over 5 months after your surgery.
Right. I have the visit was the 30th of April, 2010. Yes, sir.
So we're looking for an MRI after that date?
Right.
I'll try to see if I can find exactly what.
Well, the next MRI that I had was the 27th of August 2010, so that would have been about 3 months later, 4 months later.
And what caused you to ask for a second MRI?
Well, just continued pain. Was
it that normal that she wasn't healing as expected from the first surgery?
It happens, yes. Yeah, that was the... So it doesn't look like the MRI was attained for a couple months, but that was the thought. Maybe the plan was back after the MRI, see it again on the 28th of May, 10 weeks follow-up, continued pain and inflammation in the knee. Felt that the kneecap, the patellar tendon was inflamed at that point. We needed to back off on the therapy to let the patellar tendon settle down. It was painful at the time, painful with activities. So the plan was continue therapy, initiate an anti-inflammatory for the tendonitis, and then utilize modalities, which is DP ultrasound for the patellar tendon. That goal is to settle down the patellar tendon and then back in a month, which we did in looks like July 2nd of 2010, and at that point the pain persisted in the patellofemoral joint, patellar tendon, anterior knee was still painful.
Now at this point we were getting to the point where you thought there was something more wrong here other than the physical therapy that was causing the pain.
It's possible. I was really, at that point, we were really focusing on the patellar tendon because that's where most of the discomfort was. We were trying an injection on that day. We use injections therapeutically and diagnostically. Therapeutically because it will cut inflammation. It's the strongest anti-inflammatory that we have. And diagnostically because if it takes the pain away, then we know that's where the pain is coming from. So,
what results did you find?
We injected the knee, started back then in August of 2010, continued to have pain in the left knee, increased with activity. Before it was a 4 out of 10 now, she was a 4, before it was a 7, so there was some improvement with the injection, but I felt that in a physical exam, her muscles were still weak. The quad was still weak. We wanted to try a device called an electrostimulation device that stimulates the nerves, stimulates the muscles to try to enhance the strength and diminish the discomfort. The plan was to back in the month, which we did see on the 10th of September. And it said there may be a recurrent tear with a previous tear, meniscal with meniscal cyst, possibly. It appeared that the meniscus had partially healed, but in the interim had generated a cyst, which incomplete healing. There's a definition for healing of the meniscus. It has to be greater than 50% of the height of the meniscus. It doesn't have to be, that's still considered a healed meniscus. You have to have definitions for research purposes, and that's the definition. So at that point, because the meniscus had only partially healed based on the MRI, the plan was to rescope her knee.
I know it's going on.
Correct.
And you did that on when?
We did that on
That's the 23rd. So whatever.
Yes, sir.
Of 2010.
Yes, September 2000.
That was what you did, what the findings were.
Well, we saw scarring where the plantar was. The meniscus was torn. The tacks that we used before to secure the meniscus had dissolved. The ACL, the ligaments were intact, but the tear by the posterior horn was partially healed, not completely. So the plan was to perform just a resection of that small portion of the meniscus.
As a result of your findings in the second surgery on September 23rd, 2010, and you found that the meniscus was still a tear. Did the patient give you any history of interim trauma, exterior trauma, that may have caused care for you to go in, or whether with not a complete heal after your first surgery.
Yeah, there was no trauma. She's been diligently doing therapy, and
So all of this is still a result of the original trauma that you testified to that occurred on August 16th, 2009, when she fell on the floor of the grocery store.
yes, sir.
Yes. And so after you noted your findings and the second surgery, what, if anything, did you do?
We just performed a small meniscectomy.
You removed something.
We removed part of the meniscus. Yes,
What was that?
because the part that didn't heal, you try to enhance the environment to make it heal, and if it doesn't heal the first go around, we get just the portion of that. There was still the bulk of the meniscus is still intact, but we do take a small portion out to try to stabilize that. Take that called stress riser out, and the stress riser is just the area that's torn. So you smooth that down to smooth out the meniscus, and you try to eliminate that discomfort. We started, no, it was still painful, of course, because it was post-op, immediate post-op period. We started therapy again, but she was still having difficulty. We saw her back on the 11th of October, continued to have pain. Relief was improving as it related to range of motion and swelling.
We're still in 2010, correct?
Correct. There was still discomfort in the knee. I think I'm looking at my note here, and I put car accident, and obviously it was from the fall. I knew it was I knew it was an accident. When I dictated it, I just don't know what's wrong with it.
There wasn't a car accident. You verified that later, I presume.
Correct. Yeah, there's no car. When I see that, I try to correct those misspeaks. But saw her again on the 8th of November 2010. Some improvement in the VMO, some improvement in the quad. They were firing, and there was no significant swelling in the knee. The hope was that we now were on a better path to reverse the effects of the fall and the meniscus tear and plica resection. Again, on the 6th of December, some improvement. VMO was firing, quad was firing. The plan was to continue therapy. Strength was improving on the 1st of the 10th of January 2011, and the plan was a home program. I think at some point there was she went to, we discussed possibly fluid replacement therapy, and the patient went to Northwestern to Mark Bowman, who was a gentleman that I'm acquainted with. I know some of his partners very well, but Dr. Bowen and I have kind of a working relationship, and he's a great guy, and they of course, that's a notoriously popular, good hospital. And what would he be able to do? Why did you refer to him? Well, the thought was just to get a fresh set of eyes and someone who has this expertise in. He works with Gordon Weaver and those guys, those team physicians, and just to see they have, if you want, quivers in their arrows in their quiver and in their armamentarium, so we see. And ultimately, I think Dr. Bowman sent her to the Rehab Institute in Chicago for kind of directed therapies, and that was the plan.
At some point in time, Would you also suggest to your patient that some injections, special kind of injections, would be perhaps appropriate?
Yes.
What are those?
At the time, we were only a couple of preparations in the market. We used Silisk, and that was the suggestion. It's a series of injections, a week apart for 3 weeks that feed the cartilage that's left. It's actually made from rooster comb. The rooster comb has the same material that the substance of the particular surface is made from. So there's a couple of studies that have come out that show that the injection of the Silisk or Halligan or Brazil, any number of preparations, actually feeds the cartilage that's left. Again, the goal of that is to break that pain cycle, get the inflammation to settle down so that the swelling won't diminish, and then allow the muscles to strengthen. And that was the goal. So that was our suggestion. I think that ultimately that happened up in the Northwestern.
Okay. Now we're about 1 year postoperatively. She was still having problems with pain in that knee, correct?
Yes.
No other intervening history noted in your records or your recollection of asking her about that history? Other than the fall, of course, she's going to fall. So we still have the opinion that the complaints that you experienced even 10 or so months later after the surgery were still possibly caused by the fall that she had on Frank Ventus or August 16, 2009. Is that correct?
Yes.
And is that based on reasonable degree of mental safety?
Yes, it is.
All right. And what happened after that,
I think that she was trained at Northwestern for a while, because that was that 10 January 2011 was the last time I'd seen her until the most recent events of 14 March 2014.
Can I interrupt quickly, Doctor? I think that's, you have 2 copies of those last 2 visits in front of you?
Yes.
I know we just got those there, so you can follow along. Thank you.
And so then,
now we're talking about when, sir?
The 14th of March 2014.
She came back to you for additional treatment?
Correct.
And in the interim, she had been doing physical therapy up at Northwestern and any other centers for pain management?
And that's possible. I don't have any records from them, but I believe by history I think that's true.
So now she's come back to you in March of 2014, which is a little shy of 5 years. Wait a minute. 09 was when you initially saw her, right? Correct. Now we're into 2014.
Correct. So I'm just
About 5 years. And in the interim, she was having various kinds of physical therapy. Did anyone do those, I can't pronounce it, but I think it's spelled SYNUISE injections?
Yeah, Silisk. Silisk, yes, and they have been done that. By history, the left knee continued to have a little bit of pain. There was fluid, the generic term is fluid replacement therapy. And so, because you inject the fluid, it actually helps down-regulate the inflammatory response of the knee, diminishes the fluid accumulation in the knee, and it feeds the cartilage. There's different preparations that provide that sort of treatment.
Sometimes called that cocktail.
It could be, that's right,
A mixture of healing components.
correct. And so, on history with the she had full replacement therapy in the summer that helped for a period of time. I was able to help there was no sort of swelling or fluid changes at the time. And then it was sort of the same kind of anterior knee pain and capsular or telefemoral issues, and the plan at that point was a repeat MRI.
So now we're into what, a third?
Yes, sir.
Fourth MRI? Third. And this was under about March of 2014.
Correct.
And did you do that order?
We did.
And what was the results?
The MRI report, so we reviewed the report and the MRI felt that the report indicated that it was unremarkable, the ligaments were intact, and there was no evidence of meniscus tear. So all of that business with the meniscus that had happened several years earlier, with the repair attempt and the inadequate repair and the partial debridement had finally healed up, settled down. Still painful though, based on the last visit, there was felt there really wasn't much more that we could do to continue the home program, try to keep the muscle as strong as possible.
At some point in time, did you conclude that you reached MMI?
Yes, sir.
Explain to the jury what that is.
So MMI is just an acronym for maximum medical improvement. When you try different therapies and modalities, surgeries and physical therapy and other things, and you reach the extent of what they normally will provide, and there's no further improvement in the medical outcome. Usually we suggest that after treatments, it's about a year's time, that once at a year is where you're probably going to be, that you won't get much more improvement. And this was several years out, and so you've been diligent about doing our exercises and followed up with some money to get through replacement therapies and to every possible modality to try to diminish the discomfort. That was the best we could afford at that point.
She, for all practical purposes, have reached the maximum level of improvement she was going to get based on the current status of orthopedic remedies available.
Correct.
And what then do patients do that reach MMI and have still pain I guess you can't replace the meniscus.
There's another objection to a foundation that should be with reference to this patient's condition and treatment.
All the things we talked about, coach. No job description is required.
Right, it's going right from the record. But yes, you can. There are meniscus transplants available, but the amount of meniscus that was removed did not rise to that level. You need to do essentially what's called a subtotal meniscectomy, which is a 90% meniscus removal. This was something more in the order of 5% to 7% meniscus, maybe 10% meniscus removal. So you never consider a meniscus transplant for several reasons. One, it's the inside edge. They do far worse than the outside meniscus. So, and more importantly, they don't always heal completely. It's the same situation we were in before. And if you remove the entire meniscus, hoping that the transplant, a cadaver, dead meniscus, is not going to be any better.
Discharge. Body destroys badly.
Or at least a partial knee replacement. And
Like they go back?
And even the newer ones last only between 20 and 25 years. So at 40, should be a revision at some point in your life. And you're better off managing either pain management, strengthening, modalities, and not pursuing to a transplant.
So, partial replacement. Christy Klein was a young lady, you're putting an old 9 and 14, correct?
Still is.
Approximately how old is she? You reckon
39 years.
So having reached MMI, what does orthopedic medicine offer?
Systematic anti-inflammatory pain control, exercises, electrostimulation on an ongoing basis.
As a result of this fall and the injuries sustained, having reached MMI, does she have any degree of permanent disability?
There is, from mechanically part of the meniscus was removed, and that's a 5% permanent impairment for the whole person. And then as it relates to the weakness of the quad and the difficulty to risk the stairs, another 5 to 10%, so anywhere between 10 and 15%.
And ongoing pain and discomfort also create additional disability?
It is, but it's not part of the equation. Pain is not part of that objective equation. You're going to quantify it, so it's just not out of it. There's a book that gives us, it's called PPI, partial permanent impairment, rating, and that pain is
The American Medical Association, volume.
yes, sir, it comes from the AMA. Yes.
All right, so at this point, your only hope is pain management. That is
Yes.
making her as comfortable as you can, and that means medication every day.
Yes.
Pain medication.
Whenever the sort of root is root problems with patient and pain management.
All right. Are you still in the process of suggesting further treatment for her pain management? Is she still a patient of yours? Ongoing?
Well, the last time was as needed, and yes, you're welcome to come back anytime. But the my understanding is that pain management is kind of where the show.
All right. With all the things that I've asked you and you testified to today, based on your opinion as it relates to reasonable medical survey, reasonable degree of medical survey.
Yes, sir.
Okay. Let me ask you about your charges for services to her. Do you have a copy of your bill?
I do. Yes.
Report. What was your total charges if you have that figure available to you from your records from when you first started to treat her as of 7/14/09 to date?
I really don't. I don't think this is complete, but it says total charges were $11,200. I'm sure that doesn't include all of the.
That's my case. That is, I think this exhibit, what it means to pay or one pay for deposition purposes. I'm not sure you've been marked as exhibit A. Can you tell me what that document is?
Well, of charges just says the headaches and involved costs dealing with aggravations. Between 12/14/09 and 3/31/14.
And the left column, well, the left column is the dates of treatment.
Correct.
And the next column was the total amount charged, right?
Correct.
Yeah. Can we get off the rest of the line? There's another Good Al back on the record. I was on 16 here.
No further questions. I've got some questions, sir. Basically, glad as well. I have your check today. Okay. My business is one for identification. That's it.
Oh, with that,
I'm sorry, that you're right. It's a truly accurate copy of your chart. And we supplemented that with those extra pages from the last two visits. They are the same exhibit 10. So I have that right. I know you mentioned you wanted to correct your chart, which referred at one point to an auto accident in the chart, and you meant probably the fall. Correct. Aside from that, your chart is a true and accurate record of the care and treatment of a patient in this case. And I know your ego as an osteopathic doctor as opposed to an MD, but my experience, you take the same medical boards?
We do, yeah. And it's all one board now.
Right. And so you're a physician and a surgeon. You generally practice within the field of orthopedics.
Yes.
And I don't want to go too fast, but I know it's Friday afternoon. So if I'm talking too fast, so we'll just slow me down. And my understanding is you specialized in orthopedics since 1990 or so. And I believe you said on direct examination that at least, if not more than 50% of your practice relates to knees. Yes. And taking arthroscopic surgery is commonly utilized with regard to knee compliance problems. You gave us some terminology on direct examination, but you could just give us a quick medical lesson. What are subjective complaints to a physician?
Subjective complaints are the complaints that the patient provides.
So if I tell you I have a headache, as I sit here today, that's an example of a subjective complaint. Because you don't really know whether I have a headache or not, just like I'm telling you right now. And as part of your training and practice experience, I think you can make a note of any significant complaints in your chart.
Can we look here this? You hear it?
Here's findings that we need to listen. Specific tenderness, swelling, atrophy, working of muscles, objective findings.
And those are the kinds of things that you can determine by your own hands-on examination. And I think you can also secure objective findings as a result of certain diagnostic testing. So like X-rays, MRIs, those kinds of film studies.
Yes.
What is the term history into a physician?
Part of the chart that the patients provide. It could be a history form that's filled out. It could be a verbal discussion. It's the history. It's what happened.
Okay, do you take your own history from a patient?
The first part of my chart, that top line is the history is taken by the intake nurse. Okay, and patients are put in rooms. Okay, do they have to take their own history as well? Yes. Okay, and by history, we're not only referring to something that's recent, but we might also refer to our complete medical history dating back a number of years. Correct. So in other words, if I show up and complain about problems with my hip, it would be important to find out if it was from a recent injury or condition, or whether it's something that I had as a kid, for example. Correct. So it's important that a patient gives you a full and accurate history as part of your care and treatment of the patient. Yes. So you necessarily have to rely on what a patient tells you in terms of their medical history. Yes. What does the term acute mean to a physician? Something that recently happened. It's a recent onset. Correct. And how about chronic? What does that mean? Something that's been happening for a while. Chronic condition is something that develops over the course of time. Yes. Maybe wear and tear, degenerative kinds of conditions. Yes. In other words, it takes at least months and probably years for a chronic condition to develop. Yes. Do you know what physicians, if any, that the plaintiff in this case saw before she was referred to your care? My understanding is Dr. Tremaine, and likely her primary care, which was July-based, because the MRI came from Dr. Davidson, and by history there was an evaluation of Dr. Tremaine. Okay, Emily, when she first reported to you, you had a copy of the MRI that was done on September 3, 2009? Yes. Have you ever had occasion to look at records from any of her other physicians or medical providers? No. Do you know what her diagnosis had been from any medical providers before she reached your care? No. But in any event, I'm sorry, do you know how she was referred to you? Or did I ask that? I don't know. Okay. My understanding was the MRI of September 3, 2009. Do you have the phone here? Or available there? That's a film study that's done by a radiologist. Correct. And a radiologist is a physician who specializes in film studies and interpreting film studies. Yes. And you regularly rely upon medical opinions and reports from other physicians and medical professionals as part of your care and treatment of the patient. We do. And referencing this MRI of September 3, 2009, it referenced the soft tissue contusion in the anterior aspect of the knee joint. Yes. And the anterior will be the front of the knee. Yes. And it's anterior to the patella and the patellar tendon. Yes. With a small joint effusion. Correct. And what is effusion? Swelling fluid. And it says no marrow edema. What does that mean? That would be fluid inside the bone marrow, consistent with a fracture or a tumor or something. Okay, and it was negative for any fracture or dislocation. Correct. So there was no bone abnormalities that you could see from the diagnostic test. Correct. And then similarly, there were no patellar cartilage abnormalities from that test. Correct. And no cruciate ligament tear. Correct. It also states there was no meniscal tear. Yes. So generally speaking, aside from the fluid or contusion, it came back within normal limits? Yes. And from your initial examination on December 14, 2009, I know you referenced that you looked at the MRI and thought it was positive for this bursitis and tendinitis. Correct. And just define for us what bursitis is. Bursitis is inflammation of the sac of fluid, which is the bursa that surrounds the knee. There are 11 bursa around the knee, and this one in the front of the knee is the prepatellar bursa. And these are going to be sort of fluid-filled sacs? Correct. It's like a bumper or a cushion. And what's tendinitis? Inflammation in the tendon. And I know you talked then about also that the Hoffa fatty cat, later by December 28, 2009, we wanted to, we just wanted to I guess, investigate whether there was some involvement with regard to this Hoffa fatty cat. Correct. Which again is some kind of, well, it's a food-filled sac, or it's more fibrous. It's fibrous and it's a protective. It's a fat pad with structure. Gotcha. Yeah, that's right. So like a deal with a hand. Right. At that point, actually just prior to that, you ordered another diagnostic test of the left knee, a bone scan. Correct. And that again was a more detailed study to check for any other conditions in the knee. Correct. And the bone scan came in as negative. Yes. And that again is sort of within normal limits. Correct. You mentioned on direct examination that you started checking for some kind of metabolic condition you wanted to rule out? Correct. Just to make sure that there was no other issues as it related to or possible rheumatologic inflammatory conditions. Again, just briefly, what are the kinds of metabolic conditions that can contribute to cause these kind of complaints? Rheumatoid arthritis, ankylosing spondylitis, any of the arthritides, we call them, anything that causes arthritis. You can have conditions called Sjögren's syndrome. There's a whole bunch of inflammatory, I guess the best way to put it is inflammatory conditions that would cause pain and swelling. Okay. So even some people with I guess certain types of dystrophy or even diabetes, then that can also cause they can't sure. Yes. So just looking off any other potential causes at this point. And then we eventually move on to an arthroscopy that was done on March 18, 2010. Correct. It's unclear. You first saw her approximately 4 months after this incident at the grocery store. Correct. And then the surgery is done some, if I'm good at the math, well, what, 7 months or so after the incident at the store? Correct. And the arthroscopic surgery, again, is very minimally invasive, small incisions. Yes. 2 incisions? 2. You said about 1/2 inch or less? Less. And is that a same-day procedure? Yes, outpatient surgery. And my understanding is that one of the great advances of arthroscopy is that you can also use it as a diagnostic tool. Correct. And that's in essence what you were doing here. Yes. Because then you say, let's take a look inside and see what's going on in the knee joint itself. Right. So it gives you the opportunity to have a direct, close-up view of all the structures of the knee. Yes. And again, I'm paraphrasing, but the idea is once you go in there and you look around and you can probe and you can assess the entire structure of the knee. If you find something that is in need of repair, you would move ahead and repair it during that same procedure. Yes. In other words, there's no sense in going back later on. We'll just do one-stop shopping. Correct. For lack of a better term. And that's what was done with regard to this arthroscopy of March 18, 2010. Correct. And again, I know it's a Friday afternoon push here, but the diagnosis made from that arthroscopy was there was a tear of the medial meniscus. Correct. And I know you also use the term cartilage. Same, interchangeably. Correct. And medial is at the inside of the knee? Yes. And lateral is the outside of the knee? Correct. So she had a tear of the medial meniscus of the left knee? Yes. And that's what you were able to repair during the arthroscopic procedure? Correct. You also mentioned a finding there with regard to plica. Yes, is that right? Yes. And my understanding from your explanation is plica is basically tissue remnants from our development when we're still in our moms. Correct. As the body is slung. Yes. So sometimes there are certain levels of that tissue might be absorbed as we develop. Yes. percentage of it is. Okay, and those portions that may not absorb or remain are tissue remnants, and those are commonly referenced as plaque. So this is the kind of condition that the plaintiff was born with. Yes. Approximately how many surgeries do you do to repair medial meniscus on an annual basis, monthly basis? You probably do 3 or 4 a month. You try to repair meniscus if you can. So, I don't know, 30 or 40 a year. Possibly, I wouldn't round up, I would round down. So, just that's roughly between 30 and 40 meniscus repairs a year. Other than meniscus. Medial meniscus is far more common than the lateral meniscus, both tear and vastly more common to repair. Okay, easier to repair than the lateral meniscus because the lateral meniscus has what's called a hiatus, in the area that it's not attached to the capsule. And when you tear through that, there's not a good meniscus repair device that's readily available. Okay, and I know you put it differently, but my understanding was on direct examination, you're saying the lateral meniscus has more play than the medial. Correct. So it can be more problematic than the medial meniscus. Right. But anyway, you typically do a 40 or so medial meniscus arthroscopic repairs on an annual basis. In terms of potential causes of medial meniscus, I assume it can be trauma. Yes. Meaning some kind of impact, like a fall or a twisting kind of injury. Yes. Are there other intermedial meniscus tear be caused by a chronic condition or degenerative condition? Yes. Just explain how that occurs. Well, as we mature, the integrity of the tissue, the quality of the tissue starts to break down. Literally, the bonds that hold the basket weave together start to break down. And that's got a name. We call it mucinous degeneration. But what it really is the quality of the tissue starts to diminish. And you can see that because it's just part of the natural aging process. So that the bit of the meniscus, the substance, the thickest part of the meniscus, starts to get this kind of, in fact, when you scope the medium and you see it, it's actually kind of a yellowish material because the meniscus is, when it's organized, just like a crystal, right, a diamond or a gemstone reflects light because it's organized in a crystalline structure. The collagen fibers, the tissues of our body, are actually organized as well, so it reflects light in a regular pattern. So healthy tissue has an opalescent sheen to it. That's the analogy. It's organized like a crystal, so it reflects light like a crystal, so it has a nice sheen to it. When it loses its integrity, when it loses its connection, and you lose some of that crystalline type structure, for lack of a better analogy, that organized structure of the fibrous tissue, then it doesn't reflect light the same way, and it looks more, the colors aren't as vibrant, and it has a different quality of a feel to it, even just by probing it. So that's the breakdown. So a degenerative tear is a meniscus that's undergoing that breakdown of the fibers, losing its integrity, and then it doesn't take much to cause it to tear, the twisting. Just normal activities, the deep knee that you normally be able to manage can cause a tear of a meniscus that's starting to fail. Okay, so that's an example of something that happens as part of the aging process. Correct. Degenerative. That's the classic description of degenerative. Under other potential causes of medial meniscus tear that can be the result of repetitive trauma or types of activity with the knee. I suppose, and I should ask, what's repetitive trauma or repetitive motion? Well, just doing the same thing over and over again. setting is the first thing that comes to mind. Usually the meniscus is pretty resilient for most activities. It's not until there's some event, a misstep, for a runner, for instance, if somebody's a runner, they might misstep, cause that twisting when the knee is loaded, and that would cause could be enough force to cause the meniscus to tear. The meniscus, the amount of force to cause the meniscus to tear, that, as far as I know, has not been measured. We know an ACL takes 54 Newton meters per second squared. That's just a measure of energy. The amount of energy it takes to tear an anterior cruciate ligament. And honestly, I think that no one's looked at the meniscus because the meniscus changes over time. So when you ask what would cause the meniscus to tear, it's different stages of life. When you're young and a teenager, it takes a violent injury, crash on a bike, crash on a motorcycle, or a car accident, amount of force. As we mature, that the amount of force that is required diminishes over time because of the breakdown of the fibers that we talked about. So it's the reality is the running or the gymnastics or the aerobics or whatever that someone can tolerate when they're 20, 30, they won't be able to tolerate it at 40, 50. You've got to modify them because the same activity will cause a tear. I've heard people bend over to pick up their golf ball out of the hole, 1,000 times or 10,000 times, and just enough torque at 60 to cause the meniscus to tear, when up in the first 50 years of their life they never had.
Okay, and that's what led to my question. I was looking at my notes from the director. You talked about runners or gymnasts or people who have a certain types of level of activity or motion that would impact on the joint and involve the medial meniscus as well.
Correct.
So a person's type of activities and level of activities can be something to consider in terms of identifying potential causes of medial meniscal tear. In terms of bursitis, is that another condition that can be chronic, develop over time?
Yeah, you can get bursitis from any number of activity. Yes, you can have chronic bursitis as well.
Tendinitis as well, can that be a chronic condition that develops over time?
Sure.
In any event, turning back to your arthroscopic surgery of March 18, 2010, you were able to repair the medial meniscal tear.
Correct.
And then while you were in there, you also corrected, I guess, some of the plica.
Yes.
And what, just basically remove it? Tissue that's not needed to get out of it.
Correct.
So the surgery itself was successful.
Yes.
Patient tolerated the procedure well.
Correct.
A good healing process thereafter, no infections, things of that nature.
Correct.
Good vascular health after the surgery was completed. And neurologically intact after the procedure was completed.
Yes.
And by neurologically, we're talking about the nerve function was good, not affected.
Not yet.
And by vascular, we're saying blood flow was good, not affected. So by all accounts, the surgery was successful in terms of completing its purpose.
Correct.
And thereafter, and I'm not going to go through every visit, but then thereafter you had some follow-up visits with the plaintiff to monitor her level of healing and improvement.
Yes.
And she was also participating in some level of physical therapy sometime after the surgery, again designed to improve the strength and the healing process. And from looking at the notes, it appears that she was referencing improvement in terms of strength. Her doctor complaints even as of March 30, 2010 was that she had improved. Her range of motion was improving as well. Why is range of motion important?
It's a measure of the amount of swelling in the knee. And when we agitate the capsule, We want to make sure that it doesn't cause a contracture where it tightens up and diminishes the motion.
Okay, and again, without going to each visit separately, she initially showed some level of improvement for the first several visits, and then she began to report recurring pain, the pain coming back, pain or discomfort, I think is the reference as August 6, 2010.
Correct.
And that's where it said that on a scale of 1 to 10, her pain was now up to a 4.
It had been 7 and it's been kind of waxing and waning.
Okay. And that's when you ordered that second MRI of August 27, 2010?
Correct.
And, summarizing that, it did show some kind of tear of the same medial meniscus.
Correct.
Which referenced as an oblique tear. So is this a tear of a different portion of the medial meniscus than what you repaired?
I don't recall. I've seen both scenarios. That part of it doesn't heal. I think based on my op report on the second procedure that it was an incomplete healing of the previous tear. Yes.
Okay, so there had been some healing, but not complete.
Right.
And whatever there had been some now, new portion that was gone.
Correct.
For lack of am I explaining it correctly?
Yes.
Okay. You also mentioned in that MRI, as well as I think your ultimate report, that she had some kind of cyst in the knee as well?
In the meniscus, right.
Okay. Is that a Baker cyst, or what is it?
Oh, it's a meniscal cyst. It's a function of the torn meniscus. And that's what prompted the partial removal.
Okay, so it's just a growth on the meniscus?
The fluid accumulates. The cyst is just a fluid sac, so it accumulates in the area of the tear.
I see. Okay. All right. So then you decide to do a second arthroscopic surgery on September 23, 2010?
Correct.
And that then confirms what you suspected in terms of your diagnosis for the tear of the medial meniscus?
Correct.
And you repaired that, as you referenced on direct examination.
Good.
And you also talked about condylomalacia of the patellofemoral joint.
But that's softening of the cartilage of the kneecap.
And is that a wear and tear kind of chronic condition?
It's a chronic, chronically, it changes over time and it progressively gets worse.
And then you mentioned a large medial plug.
Right. There's scarring in that area. So where we resected it, there's scarring, so we resected that scar tissue from the medial plug.
Okay, so the plug that you took out on the first scope is now going to start over 2 or 3.
Correct.
So you're going to take out that excess while you're in there.
Correct.
Gotcha. All right, and again, you accomplished the aims of this surgery on September 23, 2010.
Yes.
No complications. The patient tolerated the procedure well.
Yes.
Again, vascularly intact, neurologically intact, good healing thereafter.
Yes.
And then you continue to follow up with her after that surgery for a period of time.
Correct.
And again, summarizing, but she was returning to therapy to improve her range of motion, strengthening of the knee, things of that nature. And by, I know, October 11, 2010, she's about 2 weeks after the surgery, and you noted in your chart that she was doing well, and her knee was improving and her range of motion was improving.
Correct.
But you told her to continue with the therapy and exercises to improve the range of motion and the strength.
Correct.
By November 8, 2010, again a follow-up, you said she was showing improvement in the VMO and quad. What's the VMO again?
The vastus medialis obliquus muscle, the part of the quadricep muscle.
Okay, and you said both are firing well. What's that mean?
That means that they're showing signs of life after the surgery. The muscles will shut down, and then they're starting to show signs of recovery.
Reinvigorating.
Correct.
Might be better tomorrow. So that's a good finding. And you said there was no appreciable effusion, so no fluid or swelling. And you just recommended, again, exercise and range of motion strength improvement. By December 6, 2010, you referenced, again, that she had been improving, the pain was minimized, and she was doing better with activities of daily living. Correct. Is that right? And you said her range of motion and strength were still improving? Yes. And again, stated the BMO on quads are firing. Right. And then, similar findings as of January 10, 2011. Right. Now, then there was an interval where you didn't see her for what, 2 years almost? Correct. So that's of January 10, 2011. Was she released from your care at that time?
There was nothing in the note. Normally I say followed on an as-needed basis, so I think there was she sought at that point.
Oh, in terms of Dr. Vaughn at Northwestern?
Yeah.
Now, did you refer her to Dr. Vaughn or somebody else?
No, I don't believe that I did. I know Mark Bowen, but I usually a closer friend of mine is Gordon Miller, who is the team physician for the bears, and so I generally tend to send people to Gordon Miller. I've not had any problem with Mark Bowen. He's a nice guy, and but Miller is a friend of mine.
Okay. And then the council, the article wants you to take a look at that. The move that after January 10, 2011, my understanding is she didn't have any scheduled visits for this point.
Correct.
So in essence, she was then released on a PRN basis.
Essentially.
Patient return activity. Excuse me, let me get off the record for a moment. Sure.
How much more do we have left of this?
About 15 pages.
You can read the last couple of questions. I don't deceive you.
As indicated, there's about 15 pages more.
Good.
That's okay.
Sure.
This is the major video unit 2 of the application factor find this 5.1650.
So we're back on the record, Doctor. I think we left off that you had released her on a patient return as needed basis as of January 10, 2011.
Correct.
At some point you learned that she'd been up to see Dr. Bowen at Northwestern.
Right.
When did you find that out?
Likely the next round of visits this year.
Okay, but you haven't had occasion to see any reports or records from Northwestern or any other physicians since that time?
Correct.
So then she came back to you sometime this year, I think it was April. Was it March? March 14, 2014.
Correct.
And you know why she came back at this point?
Continued discomfort.
Okay. I forgot to ask when we were talking about other things that can affect the medial meniscus. You talked about activities, degenerative conditions, wear and tear. And the height and weight of the person also play a role in the health of the medial meniscus. Of course. All right. Back on your visit of March 14, 2014, so she reported some, so she came back for an initial, well, it's not initial evaluation, she came back for, I guess, a follow-up evaluation of the left knee.
Well, technically after 2 years' time or 3 years' time, it's considered an initial.
Okay.
Just for killing purposes, but yeah.
Okay, and it just mentions her history of the 2 arthroscopies, and then she said she got the Synvisc injections.
Correct.
And I take it you conducted an examination at that time.
Correct.
And what were your objective findings?
just from the record here, there was no effusion, no fluid, no temperature changes, crepitation, no tenderness or instability of the knee. Just more on the kneecap with tenderness under the kneecap primarily.
Okay, so generally she had good findings except for the tenderness under the kneecap.
Yeah, anterior and inferior pole patella, and then medial lateral facet tenderness. That's both of the flat surfaces of the kneecap.
Now, is that something that, are we referring to the condylation as you mentioned before?
Correct.
Okay, so that tenderness could be due to the condylation.
Yes.
Which again is mentioned as a chronic condition that develops over time.
Correct.
Okay. Other than that, she was, there were no other objective findings?
Correct.
And certainly if there were any other objective findings, you would have noted that in your chart.
Yes.
So my understanding is then you talked about getting an updated MRI.
Yes, sir.
And seeing her after that.
Correct.
And that MRI I know is in part of your chart now too, because that's dated March 24, 2014.
Yes.
And the radiologist there uses the term impression. Is that consistent or similar to a diagnosis?
Correct. Yes.
And the impression there says it's essentially an unremarkable MRI of the left knee. Specifically, the intrinsic knee ligaments are intact and there is no definitive evidence of a meniscal tear.
Correct.
So those are all good findings.
Yes.
There's no evidence of any damage or problem with regard to the left knee from that MRI.
Correct.
So then the last part of your chart then would be the last visit of, where did they put the date here? Oh, March 31, 2014?
Yes.
And what were your objective findings at that point?
There was just global pain in the knee. That was on the inspection and palpation. Inspecting the knee, there was palpating the knee. There was continued global discomfort. Again, in the front part of the knee, the anterior part of the knee, the inferior pole, the medial lateral facets, along that scarred plica area on the medial side. There's also mild joint line tenderness, just tenderness along the capsule. That we reviewed the MRI, there were no recurrent tears, no significant fat pain, impingement, and I didn't see any irritation. Sometimes you can see fluid inside the fat pad. Some radiologists are astute enough to even pick up on fat pad impingement, and you can see that occasionally in the impressions, but not in this MRI.
Okay, so generally speaking, your objective findings are consistent with the ones from your visit of October, preceding visit. Was that October 4th? I'm sorry, not October. March 4th, 2014.
Yes.
That's what I get for trying to go too fast. So you're going to be talking about the inferior pole and medial and lateral facet. Again, this is the condylation.
Correct. That's an portion. Right.
And you found no other objective signs as of your last visit with her on March 31, 2014.
Correct.
So, put another way, everything else came back within normal limits.
Based on the MRI.
So there would have been good range of motion, good strength, things of that nature, or you would have noted it in your chart if it wasn't.
Right.
There's no reference to, for example, walking with a limp. That'd be something else you know in your chart.
Yeah.
Sure. Now, as of this last, you hadn't seen her since.
Correct.
And at that time, she was released on a PRN basis.
Yes, sir.
Patient to return as needed.
Sure.
So she could come back or she could call if she had any problems.
Yes.
You didn't put any limitations on her activities at that point?
No.
No restrictions on her activities?
No, that's how it is.
Okay, so whether work-related, recreational, home activities, no limitations, she could do whatever she could tell her.
Correct.
explanation of Defendant's Exhibit 10 before I forget, which is your chart plus the supplemental pages from the last few visits. The objection, counsel? Let me see that.
Was this at 28 pages?
It's the first compartment. Put it all together. These are all records from that issue. Well, I'm always agreeing with that. What are those handwritten notes there that I just need to look at?
This was from a meeting before was just a timeline that was generated.
Okay, well, I assume we're reviewing that. If we could mark that as Defendant's Exhibit 11, I move for admission of that as well. No objections. And those results from a pre-testimony meeting with counsel for the claim?
Correct, yeah.
That's not correct. That's something she wrote.
So it was just a timeline that was given to me by the meeting. It wasn't notes of the meeting. It was something that was handed to me at the meeting.
Gotcha. It's not your handwriting.
Correct.
Doctor, has all of the answers today been based upon your experience and training as an orthopedic physician, and have they been given within a reasonable degree of medical and surgical certainty?
Yes.
Okay, well, thank you, Doctor. I don't have anything further.
Opposing counsel asked you earlier in your examination that as to the MRI on 9309, that there was within the normal limits and no meniscal tears. That was the original MRI. And however, you already testified, and isn't it the fact as well, excuse me, that the conclusions based on that MRI are only as good as the MRI is capable of showing.
Correct.
And you already testified that not 100% correct.
That's right.
And in fact, conclusion could be as much as 50% or more incorrect. Correct?
Yes.
So, when you were asked if that was evidence of any meniscal tearing, and you said, yes, you only meant insofar as the validity of that test can't show. And as a matter of fact, you found out later that the MRI was wrong.
Correct.
But you went and found it.
So I was asking, what's MRI, the first or the second? Or the third? The first MRI. Okay. Thank you.
I think you also established that, based on the reasons of medical certainty, that the trauma that she suffered in her fall at the Strax grocery store on August 1509 was a direct and proximate cause of her tearing, her pain and suffering, and her disability that she suffered as a result thereof, correct?
Yes, sir.
There's no evidence here that you found that the tear could have been caused by a chronic condition or repetitive motions or age. And in fact, it's pretty unweighted.
Yes.
You wouldn't expect that, even if that might be a person who's active and did repetitive motions. It takes a while, correct?
Yes.
You usually don't see that in a patient like 30s or 40 years old, correct?
Or later, I mean, it's hard to put a time frame on that, but right.
More often than not.
Yeah, later.
Later. So in the history that you took, in the course of your diagnostic evaluations of her, And sitting here today, some 5 years later, and after this fall, you're still of the opinion that the cause for the present day complaints are the fact that she's still suffering from a tear of, or at least a partial tear of the meniscus.
Objection, foundation, I think also mischaracterizes prior testimony.
Let me restate that. Opposing counsel asked you a lot of questions about what could cause tears in generally people, correct?
Yes.
And you said that yes, those things can cause tears in people. But is that the case for Chrissy Hart?
No.
She didn't get complete healing of that tear, did she? She didn't get complete healing of that tear.
The first time, no. The second time, it did heal, but we removed part of the meniscus, so there is a partial permanent impairment that we talked about.
She's still vulnerable to further deterioration as she gets older because of that trauma. Isn't that correct?
Yes.
So, is it fair to say, and based on the reasonable degree of medical certainty, that from this day forward, as to her getting older and the ravages of age and repetitive motion, her disability could increase from the numbers you gave us? Is that a fair comment?
But it will continue to progress, that's right.
And when you say progress, that means disability could very well increase.
Correct.
I want to admit my exhibit, move for admission of plaintiff's exhibit 8.
I would just have to reserve objection. It's a summary based on, I'd have to see the bills basically that it references.
I think you have already built.
Well, I have to check the math and state in terms of what will correspond to the summary. I'm not certain you can compare the summary, but I just need to see what it's based upon. So if it conforms to the bills that we've previously seen, I'll refer to objection.
Subject to the possible future objection, move for objection. Any of the questions opposing counsel asked you today and your responses, has any of that changed your mind as to the ultimate conclusions that you already gave me on the direct examination?
No, sir.
Nothing that you said changes your mind about this case?
No.
Correct. No further questions.
And I take it nothing you said in response to my questions, or anything the counsel has just asked you now, has not changed your mind in terms of the accuracy of the answers you made in response to my questions. Correct. Counsel just asked you about whether things might occur that get aggravated or worsen over time or in the future. I take it that would depend on, to be more specific, you'd have to actually follow up on the care and treatment of this patient over the course of the remainder of their lifetime. It's fair to state that a number of people differ in terms of how they progress from this kind of injury. You've got a very common injury. Some people may have a little bit of no complications or advanced conditions because of the injury, and others might have more.
Correct.
So we really can't say at this point how she may progress.
Correct.
Counsel, I know I keep asking about the fall of the stagnant Van Til. And you mentioned it's important that a patient gives you an accurate history. Correct?
Yes.
you rely upon what the patient tells you?
Yes.
Did she ever report being injured in any falls aside from the grocery store fall?
No.
Did she ever report being injured in any kind of auto accidents or any kind of other mishaps?
No.
And I know counsel mentioned, they talked about some other procedures, more drastic procedures on direct examination about replacement of catheters and stuff, but you indicated she wasn't a candidate for any of those kinds of measures.
Correct.
Because you only actually removed a small portion, in this case you said approximately 5%.
Right.
So again, this was rectified by the arthroscopic surgery, uterine treatment, and therapy and follow-up.
Correct.
Thank you, doctor. I don't have anything further. Anything further?
All right. Is that it? All right, we will adjourn for the day, ladies and gentlemen. Once again, remember my instructions and admonishments are not to discuss the case with anyone other than yourselves, and only when you're all in the jury room. What do we have tomorrow? How much do we have? How many witnesses do you have?
Alana and Gavin.
2 witnesses?
Yes, sir.
All right, we'll convene at 9:30 tomorrow.
9:30.